Good morning, my dear students. Once again, I'm back with a new case presentation. Today, I have come with a very important case that is kept as a long case, is peripheral vascular disease. First of all, I would like to thank all my students and all the viewers who have appreciated my previous videos and they have subscribed me. And still, those who have not subscribed me, I would request them to please do subscriptions so that first-hand information reaches you, and I will come out with various long and short cases in general surgery. So today the case presentation, I have a case for you that is a case of Mr. Vijay, 32-year-old male. He's a Hindu by religion, resident of Kicha, driver by occupation, and he has studied till class 10th, he told. Before going into details of peripheral vascular disease, now one thing we should know beforehand, that this is a disease which affects medium and small size artery. So the large size artery is spared. If you see the diagram of the arterial supply of the lower limb, so we have a common iliac artery, then internal iliac artery, then profunda femoris artery, then there is a superficial femoral artery which is continuous as a popliteal artery. Popliteal artery gives two main branches, anterior tibial artery and posterior tibial artery, and one small branch, perineal artery. So this is the arterial system that is affected in peripheral vascular disease. Now in my another diagram, this is the picture of patient's affected limb where the greater toe and the fourth toe, greater toe and the second toe was affected. So now as far as the case presentation goes, the case goes like this. This is the way you should try to present it in your examination. So my patient is Mr. Vijay, 32-year-old male. He is a Hindu by religion, resident of Kicha. He is driver by occupation and had studied till class 10. The chief complaint of my patient is pain over the left lower limb and blackish discoloration of the great toe and the second toe of the left foot. So these are the two main complaint of the patient: pain over the left lower limb and the blackish discoloration of the medial two toes of the right lower limb. So the case presentation goes like this. My patient was apparently well when he had a pain over the left lower limb 4 months back. The pain was insidious in onset and gradually progressive in nature. Earlier patient was able to walk, even he had a pain, but at present he had to take rest, and then only he is able to walk. And the pain gets aggravated when patients stand for a longer time, or the patient had to walk a larger distance, and pain gets relief only by taking rest, or sometime on and off patient had to take medication to get relief from his pain. So this was about the pain. The second complaint is blackish discoloration. The patient had a complaint of blackish discoloration of his great toe and the second toe of the left foot. Patient says told that this blackish discoloration first started in the greater toe, and it has involved the tip of the greater toe, and gradually in the period of 2 months, this started 2 months back, and in the period of 2 months he has involved whole of the greater toe, and in the since last 1 month it has involved the second toe. And then he told that the involvement is up to the base of the toes. This is the chief complaint. Now we have to know what can cause the pain and the blackish discoloration. So we say there is no history of trauma to the region, there is no history of surgery being performed on the patient earlier, and patient, as this thing is related to the smoking we can elaborate here also, or we can take it in the personal history. Even if you elaborate it here, because at this smoking has got some relation with the disease, we can elaborate it here that the patient had been a smoker since last 15 years, and he smokes BDs, at least one bundle of BD per day. So since last 15 years he had been smoking. So this is the smoking is one of the reason. Now we what other thing can cause this thing? Other thing can cause I think is atherosclerosis, which for this age it is less common. For this age thromboangiitis obliterans is more common, but we have to rule out the atherosclerosis. Now this is the how the lower limb is affected, but we can't say we have to rule out whether other arterial system is affected or not. So that has to be taken in the negative history over here. So we have to say there is no history of breathlessness, there is no history of hemoptysis, there is no history of blurring of vision, there is no history of transient ischemic attack, there is no history of seizure, there is no history of abdominal pain, no history of pain or other limbs. So this will tell whether any other arterial system is affected or not, because that can affect the various arterial system if it has affected the lower limb. So other arterial system we have to rule out. So we have ruled out chest, we have ruled out any chest pain. For the cardiac, we have ruled out the involvement of if there is no transient ischemic attacks. For abdominal arteries, there is no abdominal pain, or there is no loss of sensation or the tingling sensation over the affected limb or the other limb or the other upper limb. There is no such complaint of the patient. So this is how you elaborate the history of present illness in peripheral vascular disease. Is it clear? So if you have taken history of all these things, now another thing, if this is there, what it can cause. So there is no history of any ulceration, there is no history of any discharge. So this can lead to the ulceration, this can lead to some time of discharge. So that you have to take it history of present illness, whether there is any then whether there is any joint pain or not. This also we have to see in case of history of present illness. So this is history of present illness for the peripheral vascular disease. Then we go for the past history. My patient is no history of diabetes. It's very important, because diabetes can be the cause of this thing, blackening, or the diabetic foot can affect the patient's lower limb, or especially the foot is mainly affected in the diabetes. So we have to take care. We have to elaborate. There is no history of diabetes, no history of hypertension. It can also cause no history of hypertension, and there is no history of tuberculosis to my patient. And there is no history of similar complaint in the past to the patient. Then we come to the personal history. Again, personal history. My patient has a mixed diet, and he is chronic smoker. He had been smoking since last 15 years, and every day he used to smoke around one bundle of BD. The patient is occasional alcoholic, on and off he used to take alcohol, but there is no history of chronicity of alcohol intake. Then family history, because as this thing is because of can be because of the smoking. So the smokers causes a passive smoking to the family. So any history of breathlessness, chest pain, or any such thing in the family is there, you have to mention. The patient, both father and mother are alive. They are mother is a diabetic patient told, so since last 15 years, and she is on insulin since last 2 years. So this is significant in history, because if the mother is diabetic, he is very prone for getting diabetes. Father does not have any medical illness. This is the family history. Then drug history. The patient, because of the pain, patient used to take painkiller on and off to get relief from the pain. Then you have to mention whether the patient is allergic to any drug or not. So in this my case, patient had not been allergic to any drug. Then you come to the general physical examination. My patient is Mr. Vijay. He's 32-year-old male. He's moderately built and nourished. He has a bit anxious look, might be because of the pain. But at present he's sitting comfortably over the bed, and he's well oriented to time, place, and person. There is no pallor, cyanosis, jaundice, ictus, or generalized lymphadenopathy. Blood pressure of my patient is 120 by 82 millimeters of mercury. Pulse is 72 per minute recorded on the right radial artery. It is normal rate, normal rhythm, non-collapsing, non-bonding pulse. Then go to the system examination. S1 and S2 is heard normally, no added sound or murmur. Respiratory system, bilateral air entry is normal, no rhonchi, no crepitations. Then the central nervous system patient GC is 15 by 15. And motor evaluation, you can do whether it is 2 by 6 or 4 by 6 or 6 by 6. What are the motor evaluation of both the lower limb? You have to do. Now after completing all these things, then we come to the examination of the patient. So examination goes like this. I have taken consent of the patient. patient. I have informed the patient what I am going to do, how I am going to examine. I have maintained the privacy and secrecy, and then I have stripped the patient below the waist, and I have exposed I have exposed both the lower limbs. So this is very important. You have to expose both the lower limb fully to differentiate between the lower limb. So on inspection, you say that in comparison to the left normal lower limb, I could see a blackish discoloration which has involved the greater toe and the second toe. This extends up to the base, or up to the proximal phalangeal and the head of the metatarsal. It has involved. Then there is there was a sign of pre-ischemia also involved the lower limb. So there is the skin of the affected limb is shiny. There is loss of fat. There is loss of hair. There is transverse ridges over the rest of the nails. I could see these are the signs of ischemia that you can see. Then there is no scar marks. Then veins over the affected limbs has got it is not that prominent. It's got guttering effect somewhere. So so this is what you see in the inspection, and you have to elaborate it. So basically the affected is this area. Now you specifically, when you describe the blackish discoloration, you can add the term there is a gangrene, or the area is shriveled or charred or mummified. So this has involved up to the base of the toes. There is a little bit edema. The line of demarcation is not well made out. There was little bit edema at the base. There is no ulceration. There is no discharge in here or in the rest of the foot. Nothing was there. So this is what you have elaborated about the affected area. Had there been ulcer, you have to elaborate the ulcer fully. You have to elaborate about its number, about its site, then about its margin, about its edges, about its floor, whether in discharge is there. All the ulcer is there. You have to describe everything about the ulcer. Then in inspection only, we do a Burgess postural test. We ask the patient to lie down at the end of the bed and raise his affected limb and see at what level we can notice the blanching. Now, to notice the blanching, it is very clear. Sometimes the patient is laborer, his foot is not well washed, or there is dust particle. So make sure the foot is fully clean. Then only you can make out the blanching. Then this comes in the inspection. Now we go to the palpation. So there is slightly decrease in the temperature on the affected part or the lower limb, and then there is in comparison to the in comparison to the normal limb, there is slight decrease in the temperature on the affected. There is a slight tenderness over the affected toes, and there is you say there is slight that tenderness is over here. Then you again you do Burgess that posture test you can do, and see, you can help out the patient, and you can see at what level the blanching is coming. Then you demonstrate the capillary filling time. You can pinch the nail and see and what time there is a refilling. If it is taking more than 20 seconds, then there is decrease in decrease in flow. Then you have to do the venous filling test. Now to demonstrate the venous filling test, like we have a vein over here. So first you have to empty the vein like this. Then you take away one of the finger and see what time it is taking to refill. Ideally within 5 seconds it should refill, but if it is taking more, then there is on lifting the limb, there is fully guttering of the vein, this means that there is decreased flow. So that you have to, so capillary filling and venous filling, these are the added tests that you have to do when you are doing palpation. Beside that, look for the movement of the joint at the proximal pharyngeal, the metatarsal joint, at the ankle joints. All the joint movements also is very important. Then for to check out the sensation, you have to superficial sensation and deep sensation, you have to check. For that, you can take a cotton swab, make a tip with the cotton swab, or you take a pin and ask the patient to close his eyes and see. First you touch the lower, sometimes you touch to the normal leg, some affected leg, see whether there is decrease in sensation or not. So ask the patient to close his eyes and tell whether you have pinched, where he is able to appreciate the pain. So superficial sensation and deep sensation you have to do. Now one of the very important part in the peripheral vascular disease is to feel for the arteries. Now for to feel for the artery, what you can do is you, in your exam, you make a chart like this. Now this is right side, this is left side. Make a chart like this and you mention about the arteries. Dorsalis pedis artery, anterior tibial artery, posterior tibial artery, popliteal artery, femoral artery, radial artery, then brachial artery, then you clavicular artery, then carotid artery, and then superficial temporal artery. These are the arteries. You have to make a chart and mention how is the flow in these arteries. Fine. I just repeat the name of the arteries. What you have to look for is dorsalis pedis artery, anterior tibial artery, posterior tibial artery, popliteal artery, femoral artery, radial artery, brachial artery, clavicular artery, then carotid artery, and superficial temporal artery. These artery where you have to look for the pulsation is coming out is nicely or not. Not to firstly to look for now the dorsalis pedis artery, which is the extension of anterior tibial artery. This you can feel just lateral to the tendon of extensor hallucis longus. So just lateral to it, you this is a grade 2. This here comes the tendon of extensor hallucis longus. You feel it over here with your the tip with the pulp of your fingers and try to feel for the artery. And if it is present, you write present. On other limb also you have to do, you write present. Then you have to feel for anterior tibial artery. Anterior tibial artery lies between the two malleolus. So between the medial malleolus and lateral malleolus, in between you have to press like this. You will be able to feel for the anterior tibial artery. The posterior tibial artery you can feel between the lateral malleolus and the heel. So this is the area where you can feel for the posterior tibial artery. Now for the popliteal artery, there are three methods to feel for the popliteal artery. One patient is supine with his legs fold. You this is the say suppose this is the knee. You put your both the fingers of the hand like this and feel for the popliteal tibial artery against the tubers against the head of the tibia. Another is you ask the patient to lie down prone, then flex his affected or the other leg. Then you feel for the popliteal artery against the lower end of the femur. This is where the next third method is the pushing or the cross leg test. Here ask the patient to sit on the chair with crossing his legs. Then if the both legs are crossed, then because of the popliteal pulsation, your upper foot will move like this. So this is the cross leg or the pushing test that you can do for the popliteal artery. Then you come to the femoral artery. So the femoral artery you can feel at the somewhat mid of the inguinal ligament, or you have to feel for the femoral artery. Then you keep on writing how you can feel. If it is present, plus, or if affected is present, then femoral artery, what is the condition? If it is not present, then you can write minus over here. Then go for the radial artery to feel for the on the both the limbs you have to do. Feel for the radial artery, feel for the brachial artery, feel for the clavicular artery, feel for the carotid artery here. This is location of the carotid artery against the transverse process of the sixth cervical vertebra. You can feel for the carotid artery, then you can feel for the superficial temporal artery. All these arteries you feel, and you make a chart. This is the chart, and you mention whether the arterial pulsations are present or not. So this is way how you look for the pulsation over all the arteries. Then you go for and see for the movement. What is the movement? Is any restriction of the movement is there in the affected part or not? Movement you have to see. So if you have done all these things, then this will complete your examination of for the peripheral vascular disease or the affected area or the non-affected area. So if there is no, say suppose in there is no pulsation dorsally pedis. So and one more important thing, always try to look for the posterior tibial artery, because this is the first artery which loses its flow if the patient is suffering from the peripheral vascular artery. So first try to feel for the posterior artery. It's very important. And in the examination, sometimes you are not able to feel. If you are not able to feel it properly, because everybody has got their different test sensation. If you are not able to feel it properly, don't just blindly say that I have felt. If you're some of your friend, he might have felt, you are not feeling this. What you are exactly perception, for your perception, you write that only. I make sure that if you are wrong in the method, you should know how to palpate, where to palpate. Even your pulsation is not coming good, or if it is there, you are saying no. That won't cut much of your marks. Examiner won't mind it if you know how to palpate for the undergraduate level. But for the postgraduate level, definitely you should, because your treatment will totally. Depend on this. So you have to know, you should know the location and how to feel for the arteries. So once you have done this examination, you can say so this is the case of the peripheral vascular disease. Now, peripheral vascular disease most commonly because of the Buzzard's disease or thromboangiitis obliterans. The thromboangiitis obliterans, there is a involvement of all the layers of the artery, small and medium sized artery. There is a formation of the thrombus that still reduces the blood supply. On the other hand, in the elderly age group only, it is a atherosclerosis, that is because of the plaque deposition or again the lipid layer is deposited. There is some pathophysiological changes that goes on, and this narrows the vessel. The vessel get narrowed and flow decreases. So atherosclerosis mainly affects the large or the medium sized artery. It does not never affects the smaller size artery. So this is how you are going to that present the case of peripheral vascular disease. I hope I have explained it well. Now a few important things you will be asked, how you will proceed for this patient. Now the first thing, beside a routine blood investigation, which includes the investigation of sugar and lipid profile, I will subject my patient to the color Doppler study or the duplex study, which is now available in mostly all the centers, and which will tell you about the condition of the artery and what the flow is there in the artery. That will be told to that will be explained by that color Doppler study. And beside that, it's important to get X-ray of the area done. X-ray of the foot. It might be it has gone deep, and there's some site of osteoblasts there, so that will come in the area. Your X-ray, your routine blood investigation, your color Doppler study. Then another study what we do is angiography or distal subtraction angiography. That is very as it is not available in all the centers, but wherever it is available, you have to do subject the patient to DSA. That will make more clear where exactly the thrombus is there, so that you can locate and make it out. Then earlier the patient used to do ankle brachial pressure index, which where we used to put our BP cuff and see where BP cuff over here just above the ankle, to see what is the difference between the pressure in the ankle brachial. The more the difference, or this means there is a decrease, more decreases the flow. Nowadays we don't do ankle brachial pressure index, but to write in the theory, and sometimes if examiners ask you, then you should know about the ankle brachial pressure index is very important. You should know how you should have, but as I told, we have color Doppler with us, angiography with us, so it hardly matters whether we are doing or not. In some centers where this facility is not there, by just mere having the sphygmomanometer, you can judge whether the patient is affected by the peripheral vascular disease or not. So next question will be how you are going to treat the patient. Now first thing, I would like to give the symptomatic relief to the patient. For this I would put the on that antiplatelet and clopidogrel. I will put the patient on this thing. Then silastazole, that is phosphodiesterase inhibitor. These drugs increases the flow in the vessel. So whatever the lumen is left, the flow will increase. Beside that, pentoxifylline that we give to the some of the patient, and we motivate the patient to keep on walking so that his walking time is increased. The second, one more question is that what is the Boyd's classification? The Boyd classification is the classification of intermittent claudication. Basically, in the Boyd's one classification, the patient walks, he have pain, but he continues to walk. As the pain producing factor, they moves off. Boyd's 2, patient walks, he have pain, he has to take rest. Then only Boyd's 1 classification, patient have pain, he continues to walk. In Boyd's 2, the patient has to take rest. Boyd's 3, that classification, patient had to take rest for some time, then only he can move. And then Boyd's 4, in the patient is having pain even at the resting stage, then this is the Boyd's 4 classification. So this is how you tell about the Boyd's classification that will be asked to you. Then if the more of the limb is affected, then you say that my main aim in this patient is to protect his limb, and we should also that amputation can be avoided. And for this, unless until line of demarcation is not made, we put the patient on higher antibiotics, and all this does what I told. And once the line of demarcation is made, then this toes has to be amputated, because there is no viability in this toes. It has to be amputated. But in the other cases where there is some chance of viability, we have to give some time to the patient, put the patient on drug, do proper dressing, do proper debridements in the area, so that the wound gets healed earliest and patient get relief from his signs and symptoms. Then if the patient is subjected to the amputation, just don't leave over here. Then I will ask the patient to contact a physical medical rehabilitation department, and then for vocational therapist, occupational therapist, I advise the patient, if the amputation has been done, say at the level of ankle or below knee, the patient will need some prosthesis. I will help him getting the prosthesis, and I will if facilities there in my hospital, that will done over there, or I will refer the patient to the center where this facility is available. So once you tell all these things, this will cover your peripheral vascular disease. I won't say that I have covered all the questions that you can read, because my main purpose was to tell you how to examine the patient and how to present the case of peripheral vascular disease. So I hope you got some basic idea about the peripheral vascular disease. Now you will be able to, or you will be in a position to describe to your examiner whenever it comes to you during examination of the arteries. Be very sure if you have felt, then only you write. If you have not felt, it's no matter. You just say it's a feeble, or I am not able to locate the artery. So don't just say, because if you say that it's present and examiner finds that it's not present, that it is really going to make some difference. So I hope you like my video, and soon I will come with you one more case presentation. At last, I would once again like my dear students to please like my channel, share my channel, and subscribe my channel. I wish you all the good luck for the future. Thanks a lot.